Chapter 11, vital signs and monitoring. A lot of what we do is investigation, and a lot of this, what we do is drawing data and seeing what a patient is. Okay, so when I say vital signs, what does that mean to you guys, or what do you think that means? Temperature? Yeah. Pulse, heart rate, respirations, right? Respiratory rate, right? So all of these things kind of tell us a big picture of how the patient's doing. So for us, with our chapter today, we're going to discuss the importance of vital signs. What are some normal limits of vital signs, mostly in adults. For this one, we're going to touch pediatrics very lightly. We're going to talk about how to take your vital signs and then the devices that you're going to be using to take your vital signs. So what is the importance of gathering information? Why is it important for us to get vital signs on our patients? To get a baseline, right? What does a baseline mean? Yeah, what's normal for the patient? And then how else can we assess the patient? So one thing that I like saying when we check our vital signs, I call it quantifiable data, right? So when we get a blood pressure, a pulse, respiratory rates, these are all numbers. Those numbers are what we use to quantify the data. Is there anything that we can see that isn't number-based that can tell us how sick our patient may be? What was that? Pupils. There's no number for pupils. Skin signs, absolutely skin signs. So these are also those other things where we need to quantify the data, but also look at our patient and how they're doing as a whole. So the tools of the trade, the things that we're going to need to take vital signs. We have this sphygmomanometer, which is the fancy technical terminology for a blood pressure cuff, right? So a blood pressure cuff and a sphygmomanometer, which I struggle pronouncing, are the exact same thing. A stethoscope, a wristwatch, a pen light, trauma shears, a pen and notebook, a pulse oximeter, and a glucometer. Okay, so these are all things that you guys have probably gathered in your equipment bags, but also when we did our gear checkouts, we should have all of these things in your bags as well for when we assess our patient. So first thing that we do is we use our acronym PRBELS. PRBELS stands for pulse, respirations, blood pressure, eyes, lung sounds, level of consciousness, which we use AVPU, skin signs, sugars, and SpO2. I know that you guys are all trying to write this down as quickly as you can. Each one of these bullet points we'll talk about next. We're going to go to our pulse. Where do we assess a pulse? Can you guys show me where you assess pulses? Yeah, do we know what this is called? This is your radial pulse, right? Let's all find our radial pulses. So the way that I like using to find my radial pulse is I put my thumb up, and as I wiggle into here, this kind of cartilage or this like ligament here, I'll just go just inside of it, and that's where I feel my pulse. Can everyone feel their pulse? So when we assess our patients, that's where we want to feel their radial pulse. Okay, we'd also go to a brachial pulse. So on our arm, inside between the bicep and the tricep, we're going to push our fingers in between the bicep and the tricep, and we're going to try to push that brachial artery next to the humerus, or that arm bone. Can you guys feel your brachial? And then we can go to a carotid. The way I like finding my carotid is I go down the jawline, kind of where the Adam's apple is, and I just apply a little inward pressure there. Can you guys feel your carotid? So all of those locations are where we can check for a pulse. You do have a femoral artery, which you can check a femoral, and then you can do a pedal pulse, which is on the top of your foot. I'm not going to have you guys digging into each other's groins right now, and I'm not going to have you guys taking each other's shoes off yet, but we'll feel those pulses eventually. So those are all the different locations that we can feel pulses. The normal heart rate for an adult is between 60 and 100. Anything greater than 100 is considered tachycardic. So tachy, or like our tachometer, that is fast. So anything that is tachy is fast. Anything less than 60 is considered bradycardic. Brady is slow. Okay, so tachy is fast, brady is slow. When we assess our pulses, we're going to check our rate, our rhythm, and our quality. Okay, so our rate, is it fast or slow, or is it just right? Our rhythm, is it regular or irregular? If someone has an irregular heart rate, a great question to ask them is to see if it is normal for them. So if someone normally has an irregular heart rate, they might have something wrong with their heart or a chronic condition such as atrial fibrillation. If their heart rate is irregular and they say that that is new for them, that might be something to look into, right? Because this new onset of an irregular rhythm might mean there's something going on with the heart. And then quality. Your quality is going to be strong it can be weak, it could be bounding, it could be thready. So your quality is like a descriptive word. So more often than not, your pulse is going to be a pulse of 78, strong, and regular, right? So the rate is that number, the rhythm is regular, and the quality is strong. So that's how we would describe a pulse. As far as respirations, we want to assess rate, rhythm, quality, and tidal volume. Rate, rhythm, quality, and tidal volume. So it's similar to a pulse. How fast are they breathing? A normal adult breathes between 12 and 20 times a minute. Quality is going to be whether it's full and effective, if it's going to be shallow or labored. Rhythm is going to be the pattern. Most people breathe in a regular rhythm. If you have a sporadic or erratic respiration, there could be something going on, such as a diabetic emergency or a potential head injury. And then as far as your tidal volume, that's going to be taking a full breath. So how is my tidal volume? Am I moving enough air in and out of my lungs? You could also have a shallow tidal volume. So if someone's breathing really fast and choppy, that is a shallow tidal volume. So blood pressure. So your blood pressure is measuring the systolic and the diastolic contraction of the heart. So your top number, your systolic blood pressure, is the left ventricle compressing or contracting. So that's your top number. The bottom number is when that left ventricle is at rest. Technical terminology, a perfect blood pressure based off of textbook is 120/80. But depending on the patient's health and conditions and however they may be, you could have a blood pressure that is a little bit higher or a little bit lower than that. If you have your triathlete or a marathon runner, their pulse might be lower, but also their blood pressure might be lower because their heart doesn't have to work as hard. Also, if you have someone who's a little bit overweight or has health conditions, their blood pressure and pulse might be a little bit higher because their heart has to work a little bit more for them to maintain that perfusion. One thing that we have is we can do an auscultated blood pressure or a palpated blood pressure. When we use an auscultated blood pressure, or when we auscultate or listen, we use our stethoscope and we'll place the bell of our stethoscope right into here at the joint and we'll listen to it. A palpated blood pressure or palpation is touch. So I can take my blood pressure cuff, I'm going to feel the radial pulse, I'm going to compress my blood pressure cuff or increase the pressure until I cannot feel the pulse. I'm going to slowly open it until I feel the pulse again. And that is a palpated blood pressure. Which do you guys think is more accurate, an auscultated or a palpated blood pressure? An auscultated blood pressure, right? So if you have to pick one or the other, the auscultated is the better blood pressure to get. When would we use a palpated blood pressure? Is on scene of a very loud, hectic scene, or potentially a trauma patient where we just need a quick number to start a treatment. But if you have the option to do one or the other, please do an auscultated blood pressure. Your pediatric blood pressures, per your textbook, you're going to see a range of 60, 70, 80, 90. Generally, most things that you're going to see is going to be 70 plus 2 times the age. Studies are showing 70 plus 2 times the age for a pediatric patient is on the hypotensive or low side of the blood pressure. So what we're looking for is 90 plus 2 times the age. That is going to be a more normal number for a pediatric patient. So if someone is 8 years old, what would be a good systolic pressure? 106, right? So 2 times the age, so 8 plus 8 is 16 plus 90 is 106. So 2 times the age plus 90. So let's just do another mental math one. If we have a 5-year-old, what would be a good systolic blood pressure for them? 100, right? 2 times 5 is 10 plus 90 is 100. There's also it's called orthostatic vital signs, also known as a tilt test. So if your patient is hypovolemic, low on fluids, dehydrated, maybe sick, you can test an orthostatic vital sign. What that is, you'll have them lie flat, you'll assess their vital signs or get your baseline set, you'll have them sit up or stand, and if their heart rate increases by 10 to 20 beats per minute or their systolic blood pressure decreases between 10 and 20 milligrams of mercury, they're positive for an orthostatic vital sign. Any questions on blood pressure? So pupils. We assess pupils with our pen lights. And when we assess the pupils, we look for pearl. Pearl means that pupils are equal, round, and reactive to light. Pupils equal, round, and reactive to light. And what that means is as we shine our pen light into their pupil, it's going to constrict. As it constricts, we're going to make sure that they're equal, they constrict at the same time, and they stop at the same time. We measure pupils in millimeters. If you look on your pen lights, you guys will have little dots that get smaller as you go down. You could always reference those dots to see how many millimeters the pupils are in. If they're dilated, it can be consistent with an amphetamine or a drug use. If they're constricted, it could be consistent with a narcotic overdose, and sometimes they can be blown. So you can have one big one and one little one. That's indicative of a head injury of some sort or a brain bleed. There's something called anisocoria, which is someone who is born or normally has unequal pupils. It's hereditary on the rarer side, but it's not that uncommon, if that makes sense. So if you have a patient that has unequal pupils, that might be a question to ask them. Hey, is this normal for you? And they might tell you that their pupils are unequal normally. Reactivity, does it change when it's exposed to light? So as I shine my pen light into their eyes or their pupil, does it constrict? And then when I turn my pen light off, does it dilate back in? Let me ask you this. If we're outside, say on a hiking trail, what do you guys think your pupils would be, dilated or constricted? Constricted, right? Because we have that much light coming into our eyes. Now, let's say we go outside right now. Do you think it dilates or constricts? It dilates so we can see, right? So we might have a bigger or smaller pupil just based off of environmental conditions as well. Lung sounds. As we listen to lung sounds, there's a couple different locations that we want to listen to lungs at. Okay, we have the anterior portion of the body, and then we have the posterior portion of the body. When I listen to the lungs on the anterior side, I try to listen just under the clavicles in the midclavicular space. So it's going to be where your clavicle is, right in the middle, kind of on the nipple line. That helps me listen to that lung in that top lobe, and there's less adipose tissue or just less tissue in general up there. You can listen to the lungs a little bit lower on that midclavicular side, but my preferred location is going to be in that mid-axillary line. It's going to be the mid-axillary is just under the armpit, and it follows this line down to my hip. I like listening into there for the same reason as the top portion, because there's less adipose tissue. There's less tissue to have to listen through in here, and you can get a better listen. If we're going to listen to the posterior side of the patient, we're going to listen just lateral to the spine, but not on the scapula. The scapula is this big shoulder bone that we have here. We don't want to listen in the scapula. We're going to come just inside. And then also same thing, I like listening on that mid-axillary just because there's less tissue to hear through. We're going to kind of talk about wheezes, rales, bronchi, and crackles as we get into our respiratory emergencies. But one thing that I want to encourage you guys now is when we hear a certain lung sound, I want you guys to start thinking of a certain patho. So if we hear wheezes in our patient's lungs, I want you guys to think COPD, asthma, or potentially an allergic reaction. And I'll explain more of that as we kind of get further. But if we hear wheezes, those are the first three things I want you guys to start thinking of to maybe rule out. Your rales and your crackles, that's indicative of fluid in the lungs. So it's also known as pulmonary edema. If we hear rales or crackles, let's start thinking congestive heart failure, flash pulmonary edema, or potential drowning or aspiration. Aspiration is when you eat food or water or drink something, and instead of going down into your esophagus and your stomach, it goes to your lungs. And then bronchi is this really thick kind of mucus. When we hear that, I want you guys to think pneumonia. So wheezes, COPD, asthma, allergic reactions. Your rales or crackles, flash pulmonary edema, congestive heart failure or aspiration. And then your bronchi is going to be pneumonia. So while we're on lungs, what's the difference between upper respiratory sounds and lower respiratory sounds? When we get into the airway anatomy portion, we're going to learn about the upper airway and the lower airway. The upper airway is at this cricoid membrane. Anything above my Adam's apple or my cricoid cartilage is the upper airway. Anything below this point is the lower airway. So if we think about sounds that I can hear in my upper airway, I want to think about what can happen in my mouth or when this swells. So if my head is down this way, I'm going to have snoring respirations, which is an upper airway. If I have fluid in my mouth, like secretions, that's going to be like gurgling, which is an upper airway. And then if my cricoid membrane starts swelling, you might hear stridor, which is an upper airway. All of these four here are all lower airway sounds because it's below this cricoid and it's in my lungs. So anything in the lungs is considered a lower airway sound. So level of consciousness, LOC. We check level of consciousness by first looking at our patient to seeing if they're alert. If they're alert, that means when we walk into the room, they look at it. So as I walked into this room earlier today, the majority of you looked up at me, and that told me, guys, you were alert to my presence. If they're not alert, we then have to go down our AVPU, right? So alert is the first part of AVPU for level of consciousness. Then we go to verbal stimulus. So if I walk in the room and you guys aren't looking at me, and I say something to you, I'm like, hey, Kobe. And Kobe looks at me, now he's alert to verbal stimulus, right? So that's verbal. Now, if your patient isn't alert to verbal stimulus, you can elicit a painful response. When we elicit a pain response, you can do a trap pinch. You can pinch the nail bed. There's a pressure point behind the jaw. So if my patient's potentially unresponsive, I'll go to the airway, do a head tilt chin lift, and maybe elicit a pain response at the jawline. That would mean that they're alert to painful stimuli if you elicit a pain response and they wake up. For a long time, we were doing something called a sternal rub, but you had big burly people doing radical sternal rubs to little frail people and leaving these gnarly bruises on sternums and chests. The sternal rub is kind of going out of vogue. It is something that still is done or it's common practice, but we're trying to push more towards that trap pinch. And then if you don't get any response for painful, they're considered unresponsive. After we check our alertness, we're going to ask our orientation questions. Our orientation questions are going to be person, place, time, and event. The best way that I like doing this is I'll walk up to my patient. I'll say, hi, sir, my name's Johnny. What's your name? Evan. How old are you?
23.
What city are we in?
Winchester.
What year is it?
2024.
And why did you call 911?
I got problems.
You got problems, right? We all got problems, right? But that's how I go to every one of my patients. My first 4 questions to them is, hi, sir, ma'am, my name is Johnny. What's your name? They're telling me the person. What city are we in? They're telling me the place. What year is it? They're telling me time. And why did you call 911? Like, why am I here? That is the event. So person, place, time, and event. Any questions on LOC? Skin signs. Skins don't lie. If I get really, really anxious, I can spike my heart rate. My blood pressure can spike. If I bear down like this, I can drop my pulse. I can change my respiratory pattern, right? So when's the last time you guys thought about breathing besides right now? Right now. So if on my case, sir, I'm just going to check your respirations, what are they going to do? Right? So we can't change our skin signs. They don't lie. So for our skin signs, I want you guys to think country music television, color, moisture, temperature. What's the color? Is it pale? Is it flushed? Is it red? Is it normal for them? Is it yellow? What's the color? Is it blue or gray? Is it bluish, which is cyanotic, indications of low oxygen levels? So those are all colors. Moisture, you can have normal, you can have clammy, you can have diaphoretic. Your normal is going to be like how we are right now. Diaphoretic is that profuse sweating, and clammy is somewhere in between normal and sweaty. Does that make sense? So the clammy is kind of that in-betweener. And then temperature, they could be hot, they could be cool, they could be cold, They could be normal. So color, moisture, temperature. And then our cap refill. When we check our cap refill, we're going to all of you guys right now, grab your nail bed and see how it's kind of white and blanched. When you release it, as it goes back to pink, it has to be less than 2 seconds. So that means your cap refill, if it's less than 2 seconds, or cap refill is immediate. If it's greater than 2 seconds, that means that there's a mismatch somewhere, which is causing your blood flow to not get back into those capillaries to refill them. SpO2 or pulse oximetry. SpO2 readers, which we have in our drug caddies in our gear, that measures the amount of oxygen that's in your blood. So on your red blood cell, you have something called hemoglobin. Your hemoglobin is what carries oxygen throughout your body. What the pulse oximeter does is it emits an infrared light through your finger, and it's reading if there's anything on the hemoglobin. If there's something on the hemoglobin, you could have a reading anywhere between 100 all the way down into 60 and lower. What we're looking for is anything greater than 94% we're happy with. If their SpO2 is less than 94%, we're going to treat that patient with oxygen. A couple things that can throw off your pulse oximeters is if your patient's hypoperfusing or in shock. So if their blood pressure is low, they're not circulating blood, you're not going to get a good cap refill, which then you're not going to get a good pulse oximeter, or you're not going to get a good pulse ox number. If they have dark nail polish, in my experience, really dark reds and blues kind of throw off your pulse ox. Any movement of the patient might make that difficult pulse oximeter to read. And then if they're cold. So if they're cold, their body's going to be shunting blood to the core, so you're not going to get that good reading or at the fingers. For sugar, our blood glucose monitors or our glucometers, we're going to measure any patient who is weak, lightheaded, dizzy, seems abnormal, any suspected strokes that they could have, or any altered level of consciousness patient. These are patients that are susceptible to having low sugars, which we can potentially correct with a treatment. A normal blood glucose reading for an adult is between 70 and 140. So other monitoring equipment, this right here is a Zoll monitor. Your ALS units will have monitors. One thing that you guys will assist your medic partner with is placing the leads on the patient. So I want you guys to think, and there's 4 colors. There's a white, a red, a black, and a green. So when I put on my 4 leads, I want you guys to think this: white over right, smoke over fire. Okay, so the white lead goes over the right shoulder, smoke or black goes over the left shoulder, fire is red, goes under the black, and then by default we have the green, grass under clouds. So white over right, smoke over fire, and the green one goes to last place. You can also check temperatures. So in a post-COVID world, everybody gets their temperatures checked just because it's can tell us if there's potential infection. You can have either an oral thermometer or like an axillary thermometer that goes over the forehead and around the ear. Those ones, depending on wherever you go, you'll be trained up on their piece of equipment. And there's something called capnography. This looks just like a nasal cannula, but it plugs into your monitor and it measures the CO2 in your body. I'm not going to dive super in depth with that with you guys, but be aware that it's out there. So if your partner asks you to place them on the capnography, you're going to use the capnography nasal cannula, and it plugs into the side of your monitor. One thing that you guys are going to be doing a lot of in your hospital rotations is going to be 12 leads. So you have 6 leads, V1 through V6. V1 and V2 are going to go into the 4th intercostal space, just left and right of the sternum. And it goes towards the left side because the heart's on the left. You skip 3 for now. You go to V4. It goes into the 5th intercostal space, mid-clavicular. So remember our clavicle, the middle of the clavicle, or that nipple line, it's in your 5th intercostal space. Okay? Then you have V6, which is in that 5th intercostal space, mid-axillary. The mid-axillary lines from my armpit to my hip, technically my armpit all the way down, this is that mid-axillary line. So if we're playing a game of defaults, if I have V2 and V4 are here, where does V3 go? in between, right? So V3 goes between 2 and 4, which means V5 goes between 4 and 6. So you guys will be doing lots of these in your hospital rotations. Assessing pain levels. This is the Wong-Baker Faces pain rating scale. The best way that I like asking people if they're in pain or how much pain they're in is I'll say, hey, sir, on a scale of 0 to 10, 10 being the worst, how would you rate your pain right now? And you're like, 10. It's always a 10. And you get the Wong-Baker scale, and you're like, nah, it's a 4, right? Pain is subjective, though. I've had guys who've had snapped ankles, and they're like, it's a 3. I'm like, do you want some pain meds? Like, no, I'm fine. And then you have the person that has a little paper cut, like, oh my God, I'm dying, it's a 10. So pain is subjective based off of protocol. Eventually, you guys can treat pain management on that paramedic level when you guys get there. History taking, the chief complaint or that event, why did you call 911? That allows us to have a base or foundation of where we're going to understand what type of questions that we need to ask this patient. What do you guys think is an open-ended question? Yeah, where's the pain or how's the pain, right? Because you're letting them come up with whatever answer they can think of. What would be a close-ended question?
Does your arm hurt?
Yeah, does your arm hurt, right? Specifically, right? And they're like, no. Then you're like, does your chest hurt? No. Does your hip hurt? No, right? So those are closed-ended questions. So the way that I like remembering open-ended versus closed-ended questions, an open-ended question is, hey, where do you guys want to go for dinner? Out of the possibility of wherever we can go, it's anywhere. Versus your closed-ended is, hey, do you guys want to go to Chipotle or In-N-Out? That's closed-ended. You have 2 options. We want to deal with open-ended questions as much as we can because that's how we gain as much information or how they input as much information as they need to for us to understand what's going on. Great things while we're doing our history taking is active listening. Sometimes we want to reflect on what they're saying and repeat it just to make sure they sound like they're heard. We want to ask for clarification. So if you're confused by anything, clarify it. Having empathy for the patient. You guys know what empathy versus sympathy is? What's sympathy? Sympathy is like, oh, I feel bad for you. Like that sucks for you. Empathy, so if that's sympathy, what is empathy? Yeah, understanding that pain that they might be having. Empathy is easy to lose. Keep it as long as you can. There's times where you're like, I'm on my 6th wake up. My last call was a super not awesome sick kid, and now you're calling me for your toe pain. That's been going on for 3 weeks. Would you like to go to the hospital? Be as empathetic as you can. Confrontation in a good way or in a professional way. This is like for the intern killer, the little old lady that's, hi ma'am, why did you call 911? She's like, well, it's been really hot outside, but the mornings have been cold and my knees have been bugging me because of my surgery back in 1986. And I have some indigestion and my tummy hurts and I've been constipated. And my dog's been barking all night. And you're like, why are we here? She's like, my dog needs water. Okay, perfect. Like we have a place to start. Or she could be like, I'm having chest pain. So confrontation is a good way. And the way that I like asking this question is, sir or ma'am, if you had to pick one thing right now that's bugging you the most, what is that? Or what can we fix for you right now? And then they tell you, that's that first priority. That would be that chief complaint. Now, if she's like, oh, I'm having chest pain and shortness of breath and I'm constipated, I'm having some abdominal pain, like she has 4 complaints and we have to look at all of them completely. But then that's when you ask her, well, if you had to pick one right now, what's bugging you the most? Oh, my chest pain. Then we start with the chest pain stuff. And then we work through all of the other things. So we need to figure out where we're going. And then interpretation, and just understanding what's going on. One thing too, if I'm on the ambulance and you guys are on scene doing your assessments and I show up and I take your patient, one thing that I will ask my patient always is I'm like, hey, Evan just gave me a report. I just want to double check with you. This is what he told me. Is this all correct? And I'll just tell the patient everything that I understood. So then she or he can tell me anything that I missed in between. So that's how we interpret that data or interpret the assessment that they're telling us. Sample and OPQRST. These right here are your assessment tools. So sample are signs and symptoms. A sign is something that we can see or that's quantifiable. A symptom is something that the patient is describing or feeling. So if I have a broken leg, is that a sign or a symptom? It's a sign. But if I'm telling you I'm dizzy, is that a sign or a symptom? It's a symptom, right? You can't prove that I'm dizzy. You can't prove how dizzy I am. So that's a symptom. Allergies, Sir or ma'am, are you allergic to any medications? Medications. What type of medications are you on, or do you take any medications? This is one of my favorite ones, pertinent past medical problems. So you guys, as young EMT students, you'll go up to your partner as you're doing your assessments, and you're like, sir, do you have any pertinent past medical problems? How would you ask a human being? Hey, what kind of medical problems do you have? Or do you have any medical problems, right? I guarantee you, all of us will say pertinent past medical problems at some point in a dialogue to someone. It's okay. It comes with time. Also with the pertinent past medical problems, I like asking, sir or ma'am, do you have any medical history, including any lung problems, heart problems, strokes, or heart attacks, right? So I just throw out this big umbrella just to remind them, they're like, oh yeah, I did have a heart attack, 10 years ago. Okay, cool, that's pretty important to me. Last oral intake, when's the last time that they ate? And events leading up to it, what were you doing when this happened? Okay, always mowing my lawn, always trimming the top of the tree, all of the things. I was sitting here watching television. All of these little visual cues or assessment cues are going to kind of tell us what's going on. We can then do our OPQRST. Onset. Is this something that came on all of a sudden, or is this something that happened gradually? Right? Is this something that came on quick, or is this something that's been bugging you for a while? P, provocation. Is there anything that makes this better or worse? Or is there any way that you lay or position yourself that makes you better? When I'm having trouble breathing, when I tripod or sit like this, it makes it feel better. Oh, my dizziness, when I lie down flat, it makes it feel better. Quality. How would you describe what your pain feels like? And this is really one of those ones where it's like an open-ended versus a closed-ended, right? So if I asked you, how would you describe your pain? Is that an open or closed question? Open. But if I'm like, hey, does it burn? Is it throbbing? Does it pinch? Is it? So you can easily, does it feel like a pressure pain? This quality easily gets lopped into a closed-ended question. Now, if you ask that open-ended question, hey, sir, how would you describe your pain? And they pause for like more than a second and a half, 2 seconds, that's when I throw in a bunch of adjectives. Is it a burning, a throbbing, a pinching, a pulling? Does it feel like a squeezing, a pressure, something sitting on your chest? And then I'll just throw out all of these things, and they'll come in with like, oh, it's kind of achy. But I fed them enough information to kind of make them or lead them to their own decision. Does that make sense? So it's sometimes you do have to throw those adjectives or that closed side occasionally. Radiation. How do you guys feel would be a good question to ask what the radiation is or where their pain goes? Does your pain radiate anywhere? Does it go anywhere else? Yeah, that's a good one too. Anything else? What I like asking, and those are both great ways to ask it, I like asking, sir or ma'am, can you point with one finger where your pain hurts the most? Here. Now I know where it's at. Does your pain move anywhere? And then they'll point to me wherever it goes. So if they're like, oh, it starts here and goes to my back. That's chest pain that is now back pain. Oh, it starts in my back and then goes to my chest. That's back pain that is going to the chest. So that's kind of why I like pinpointing, because even for your abdominal pains. Sir, can you where's your pain at? They're like, it's kind of here. Or, sir, can you point to me where your pain is? It's right here. Where does it move? It kind of goes in here. So now I got that right upper quadrant to the left upper and that left lower. Does that make sense? So I can figure out exactly where it is and exactly where it's moving. Does that make sense? Severity. On a scale of 0 to 10, 10 being the worst, how would you rate your pain? And then time, what time did this start? Or how long has this been going on? If you ask them how long this has been going on, and they say 30 minutes, look at your watch, subtract 30 minutes, and tell them, so this has been going on since about 6:15. Correct. Now I can document a hardline time in my PCR. Difficult history takers, silent patients, overly talkative patients, patients with multiple systems, people who are anxious, angry, or hostile, intoxicated, crying patients, emotional patients. These are kind of like those intern killers that are really tough, but the biggest thing is lower yourself to their level and just listen. Be like, hey, what's going on? Or what can we fix for you right now? Or how can we help you? All of these little empathetic things are going to help you break those barriers for those patients. So in conclusion, we talked about the importance of vital signs, some normal limits or ranges for vital signs, how to take the vital signs, and devices used to take vital signs. Any questions?